Now we're going to take a look at the immunizations and biologicals, just a quick review. The goal of immunization is the eradication of disease. Numerous infectious diseases, many of which are potentially fatal, have been sharply curtailed worldwide through vigilant adherence to immunization strategies and public health control measures. In the United States, diphtheria, measles, polio, and tetanus are almost unknown. However, we have begun to see measles coming back at times. Children who have not been vaccinated for religious, cultural, or other reasons are at risk for these diseases and increase the societal risk by contributing to the pool of unvaccinated individuals who are capable of transmitting infection to susceptible and high-risk individuals. This is a very personal decision for parents. However, again, as practitioners, we need to look at the whole picture and realize that if patients do not become immunized, there's a risk of spreading the disease. There's, again, active immunity, passive immunity, and various tests. Let's take a quick look at the mechanism of action of immunizations. Immunizations act to confer immunity to a particular disease. There are two types of immunity, both active and passive. Active immunity involves the administration of all or a part of the microorganism to evoke a response. Antigens are taken from living or dead organisms, and small amounts are given intradermally or subcutaneously. This process stimulates the body's immune response, and the antibodies are stimulated to protect the immunized person from greater exposure to this particular disease-producing antigen. This immunity is retained for a prolonged period of time, thereby protecting the person from the disease whenever he or she may be exposed to the antigen. The immunity can be boosted at specific intervals. Active immunization is accomplished with three different types of agents. First, inactivated vaccines or killed agents. Most bacterial vaccines and some viral involve the use of inactivated agents. These agents are not capable of replicating within the host and thus present little risk to the recipient. Maintenance of lifelong immunity requires the administration of multiple doses. Mucosal protection after the use of killed vaccines is less than with the use of live vaccines. Thus, local infection or colonization with an agent can occur along with the potential for transmission, although systemic disease is prevented. Live vaccines are attenuated. Most viral vaccines involve the use of live virus that has been chemically changed to decrease its virulence. Active infection with replication of the virus occurs in the host following administration of the product, although few adverse effects occur. This route generally produces a superior response, including mucosal immunity, and does not require the use of multiple doses. And finally, we have active immunization. This may be accomplished by the use of a modified product of an organism, such as a toxoid, which consists of modified bacterial toxins and retains the ability to stimulate antibody formation but is non-toxic. The route of administration is used against diphtheria and tetanus. Maintenance of protective titers of antitoxins require a periodic administration of boosters, especially doses of toxoids. We then have the passive immunity. Passive immunity occurs when antibodies that one acquired from a human or an animal with acquired immunity to a specific organism are given to people who do not have immunity to the organism. Newborn infants, for example, achieve this naturally from their mothers through the placenta and through breastfeeding. It can also be achieved through injections of gamma globulins for hepatitis protection or anti-sera or antitoxins. This process temporarily provides the same protection as that given to a person who has achieved active acquired immunity. These antibodies naturally break down and are eliminated from the body. All immunizations contain several different components. The immunizing agent, this active component of the product may be a killed, attenuated vaccine or a toxoid. The suspending fluid, this may be either sterile water or saline or a complex tissue culture fluid. It contains proteins derived from the medium in which the vaccine was produced, such as an egg antigen or an inactivated influenza virus. Individuals who experience anaphylactic reactions to eggs may be allergic to influenza vaccine because the egg antigen is in the inactivated influenza vaccine. Studies of MMR vaccine have demonstrated that egg-allergic children may be safely vaccinated, however. There's also preservatives in these vaccines. Trace amounts of preservatives, stabilizers, or antibiotics are often added to prevent bacterial overgrowth in multiple-use vials of the vaccines. Individuals may have allergic reactions to products such as neomycin, and that may be present in minute amounts. Thimerosal, a mercury-containing organic compound widely used as a preservative, was removed from or reduced to trace amounts in all vaccines with the exception of inactivated influenza vaccine back in 2001 because of concerns about potentially neurodevelopmental pathology in infants who may receive multiple vaccines that contain this and may be able to adequately clear these products because of hepatic immaturity. In 2004, the Institute of Medicine released a report that rejected a causal link between vaccines and the development of developmental disorders, including autism in children. The mercury levels found in the urine of children with autism were not greater than those levels without the condition, according to a large UK study. Researchers noted that other heavy metal concentrations were also the same among children with autism, children from the general population, children without the condition but who had siblings with autism, and children who attended special educational schools. The FDA is continuing its efforts to reduce the exposure of infants, children, and pregnant women to mercury from various sources, and will continue to study this. There's also adjuvants. These are often an aluminum-based compound that is added to enhance the immunogenicity of an agent and prolong its stimulatory effects. This is necessary for some of the inactivated vaccines and for the toxoids. So what are the cardinal points of treatment? In general, the recommended childhood and adolescent immunization schedule and the recommended adult immunization schedules are revised annually. Healthcare providers should ensure that they are following the most up-to-date schedules, and these are all available on the CDC website. Vaccination providers should adhere as closely as possible to recommended vaccination schedules. Longer than recommended intervals between doses do not reduce final antibody concentrations, although protection might not be attained until all doses have been administered. With the exception of oral typhoid vaccine, an interruption in the vaccine schedule does not require restarting the entire series of a vaccine or toxoid in addition to extra doses. Healthcare providers should simultaneously administer all vaccines for which a person is eligible because simultaneous administration increases the probability that an individual will be vaccinated fully at the appropriate age. An administration of each preparation at a different anatomic site is desirable. Simultaneous administration of the most widely used live and inactivated vaccines has produced seroconversion rates and the rates for adverse reactions similar to those observed when the vaccines are administered separately. An inactivated vaccine can be administered simultaneously or at any time before or after a different inactivated vaccine or live vaccine. Live vaccines also may be administered simultaneously. However, live vaccines such as measles, mumps, and rubella should be administered after receipt of an antibody-containing product such as immunoglobulin until the passive antibody response to the product has degraded. This process is dependent on dose and of the specific product. Exceptions to this rule are yellow fever vaccine, oral typhoid vaccine, and live attenuated influenza vaccine, which may be administered after immunoglobulin. Use of combination vaccines can reduce the number of injections required at a visit. Licensed combination vaccines can be used whenever any components of the combination are indicated and its other components are not contraindicated. Vaccines may be made by different manufacturers, are generally interchangeable, although it's preferred to complete a series with a single product. Vaccination should not be deferred because the brand used for the previous dose is not available or unknown. Persons without documentation of vaccine receipts should be considered non-immunized if a reasonable effort to locate records is unsuccessful. These individuals should be started on the age-appropriate vaccination schedule. Serologic testing for immunity is an alternative to vaccination for certain antigens, such as measles, rubella, hepatitis A, or tetanus. Guidelines concerning the use of immunizations are one of the most carefully studied areas in pharmacology. Joint guidelines for children are promulgated by the ACIP and the American Academy of Pediatrics. Guidelines are revised yearly as new products are introduced and recommendations for use of older products change. These guidelines determine the standard of care that all primary care providers are expected to provide. With the increase in the immunocompromised population and the increasing numbers of immigrants living in the United States who require catch-up vaccinations, the greatest challenge for primary care providers is to master the exceptions to the recommended schedule. Again, these are all available on the CDC website. Critical decisions are made in immunizations, include which products to give and when to give them. Before using any biologic, the healthcare provider should take all precautions known for the detection or prevention of an allergic or any other adverse reactions. This should include a review of the patient's history regarding possible sensitivities and ready available epinephrine 1/1000 and other appropriate agents used to control for immediate allergic reactions, as well as a knowledge of the recent literature pertaining to the biologic to be used, including the nature of the side effects and adverse effects that may follow its use. Individuals with impaired immune responses, whether because of the use of immunosuppressive therapy, a genetic defect, HIV or AIDS, or any other causes, may have a reduced antibody response to active immunization procedures. Deferral of administration of live vaccines may be considered in the individuals receiving immunosuppressive therapy. Other groups should receive vaccines according to the usual recommended schedule. What about the schedule for immunization of children? Both the CDC's ACIP and the AAP Committee of Infectious Disease has issued immunization guidelines for children that are revised annually and published each January. Recommendations for these two bodies may vary slightly, and these variances are noted in the Joint Recommended Vaccine Schedule, which is last issued in February of 2012. And again, the CDC is a great resource for looking at these schedules. Taking a look at immunizations of adult and elderly persons, recommendations for adult immunization historically was lacking. However, with the recognition of increased pertussis, pneumococcal, and other vaccine-preventable diseases in adults, the CDC issued a schedule for adult immunizations as well. This, too, is updated annually. At-risk post-procedure patients, certain populations are considered to be at risk and receive modification of the routine vaccine schedule. This, too, may be found on the CDC website. Some of the important exceptions include in compliance with recommendations for all individuals. It's particularly important that all healthcare workers be immunized against hepatitis B. In addition, healthcare workers in emergency department settings and the emergency response teams, such as emergency medical technicians and paramedics, may elect to be vaccinated against smallpox. Specific recommendations for the use of smallpox vaccines, again, all can be found on the CDC website. Travelers to many of the underdeveloped nations may require specific immunizations depending on where they are traveling. The CDC also publishes information on vaccine recommendations for travel, and this too can be found on the CDC's Traveler Health website. The CDC Health Information for International Travel, commonly referred to as the Yellow Book, is updated every 2 years and is the authority source of U.S. government recommendations for immunizations and prophylaxis for foreign travel. The CDC's Guide to Vaccine, Contraindications and Precautions is updated as well and can be found on the CDC website. Immunosuppressed individuals, including those with HIV, individuals receiving chemotherapy, and those on corticosteroids will require modifications of the recommended immunization schedule. Where possible, efforts should be made to appropriately vaccinate individuals prior to beginning regimens such as chemotherapy. And what are the principles of administration of vaccines? There's numerous myths about contraindications to administration of vaccines. It is our job to educate the public about these myths. For all currently available products, minor upper respiratory infections or gastroenteritis with or without fever is not an appropriate indication of withholding a scheduled vaccine dose. Concurrent administration of an antibiotic is not a contraindication to immunization. In most cases, preterm infants should be immunized at the usual recommended chronological age and with the recommended dose. Premature infants weighing under 2,000 grams should not receive Hep B until 1 month of age or prior to hospital discharge. Pregnancy is a contraindication to administration of live vaccines. However, pregnancy in a household member is not a reason to withhold vaccine from a child or adult. Women who are breastfeeding may be immunized with all products with the exception of smallpox and yellow fever vaccines. While other vaccines, including hepatitis A and polysaccharide pneumococcal, have not been specifically studied in breastfeeding women, no evidence suggests that trace amounts of a vaccine present in breast milk is harmful to infants. A lapse in the recommended immunization schedule does not require that the entire series be restarted. Needed doses should be given at the first opportunity as though the usual interval had occurred. Half doses of vaccines are never indicated in individuals who have had a significant reaction to a previous dose. In addition, reduction or divided doses are not recommended for preterm or low birth weight infants. Family history of an adverse event with an immunizing agent, family history of seizures, and family history of sudden infant death are not an appropriate indication for withholding recommended immunizations. Soreness, redness, or swelling at the area of immunization or a fever lower than 105 degrees Fahrenheit or 40.5 degrees Celsius following a previous vaccine is not an indication to withhold subsequent doses. Early vaccinations against pertussis, Haemophilus influenza type B, and measles, mumps, rubella in babies were not linked to the risk of developing celiac disease as well. Notification of risks and benefits of vaccines. The National Childhood Vaccine Injury Act of 1986 mandates the notification of patients and parents of the risks and benefits of individual vaccines. This legislation requires the distribution of standardized information to these individuals. A simplified version of the information pamphlets were approved by federal legislation in 1993 and is available from vaccine manufacturers, the CDC, as well as most state health departments. The legislation requires healthcare providers who administer vaccines to keep permanent records of all immunizations given, along with specific information about the manufacturer of the product and lot number of all doses. In addition, the provider is required to report occurrences of events suspected to be the result of a vaccine by using a mechanism titled the Vaccine Adverse Event Reporting System. So how do we monitor these patients? Vaccines that are administered are recommended to induce a protective immunity in more than 95% of its recipients. It is not recommended or necessary to obtain serum titers to document immunity. A UK study in the Journal of Archives of Disease in Childhood found that anaphylaxis cases in children following immunizations were extremely rare. For patients with signs and symptoms suggesting an immunoglobulin E-mediated reaction to a vaccine or its components, allergy testing by a specialist may be indicated, especially when future doses of the suspected vaccine will be needed. A 4-step protocol published by the Hypersensitivity Study Group in 2009 facilitates this process, which should preferably be performed by an allergist using the specific vaccine from the same maker that is suspected of causing the reaction. Decisions about whether a patient should have additional vaccines should be based on patient-specific risk-benefit analysis as guided by the algorithm. Some of the options for revaccination include withholding other doses of suspected or implicated vaccines for patients who have had serologic evidence of immunity, who are at low risk for disease, who have serious complications from disease, or who are at risk for life-threatening complications from the vaccine. A CDC analysis of medical records of 550 patients with Guillain-Barré syndrome showed that none of them experienced flare-ups in the 2 months after receiving vaccines, including the flu shots. Only one patient experienced a flare-up within a year of vaccination. This information should be provided to individuals with a history of Guillain-Barré syndrome who would like to receive vaccinations to prevent illness. The question of whether vaccines cause autism has remained in the minds of people despite numerous scientific studies concluding that they do not. A panel of the Institute of Medicine once again concluded that the MMR vaccine does not cause autism despite complaints from some parent groups. But vaccines are not without risk. There are risks of getting the vaccine for chickenpox that can arise years after vaccination. People who have had the vaccine can develop pneumonia, meningitis, or hepatitis years later if the virus used in the vaccine reawakens due to the unrelated health problem like cancer that has compromised their immune system. However, the same problems are far more likely in patients who are infected naturally at some point in their lives with chickenpox, since varicella zoster, the virus that causes chickenpox, can live dormant in nerve cells for decades and present later as shingles. The government asked the Institute of Medicine in 2012 to review the known risks of different kinds of vaccines to help guide decisions about compensation for those who claim to have been injured by vaccines. Legislation passed in 1986 by Congress basically absolved vaccine makers of the risks of being sued for vaccine injuries to encourage companies to continue to manufacture vaccines and force those who suffer some type of injury they believe is related to vaccines to petition the government for compensation. The government generally restricts compensation to cases involving children who have injuries that scientists scientists believe might plausibly have been caused by vaccination, including seizures, allergic reactions, fainting, inflammation, and temporary joint pain. But legal and legislative battles have been fought for years over whether to expand this list because of the concern about vaccines and autism. Much of this concern was due to a fraudulently reported study that was later retracted. Rather than vaccine causing autism, it has been suggested that many children found to be injured by vaccination have an immune or metabolic problem that becomes obvious after vaccination, or that may be triggered by the vaccination. Looking at patient variables for geriatric patients, the immune system of elderlies is less active. You need to keep this in mind. For pediatrics, immunizations are an integral part of primary care for children. Recent research concluded that childhood vaccines, with the exception of the vaccine for measles, mumps, and rubella, were not linked to an increased risk of immune thrombocytopenic purpura among young children. However, the hepatitis A vaccine was associated with an increased ITP risk among 7 to 17-year-olds, while the chickenpox and tetanus diphtheria vaccines were tied to the disorder among 11 to 17-year-olds as well. Children who were exposed to more perfluorinated compounds have been found to be less likely to respond to routine vaccines, according to a study in the Journal of American Medical Association. Researchers found that doubling in maternal blood levels of perfluorooctane sulfonic acid was tied to a 39% decline in diphtheria antibody concentration in children at age 5. For pregnancy and lactation, live vaccines usually are contraindicated in pregnancy. However, you should take a look at the individual vaccines themselves. It is usually safe to give vaccines while the mother is breastfeeding. A survey of women revealed that giving flu shots during pregnancy does not increase the risk of a miscarriage. And another study found that babies of women who were vaccinated during pregnancy retained some immunity for 2 months after birth. For patient education, with most vaccines, the arm in which the vaccine is given may become sore. This can be treated with warm compresses. Some patients develop generalized flu-like symptoms. For any feeling of malaise or flu, the patient is often instructed to take acetaminophen. Most symptoms are mild and self-limited. Reactions that should be reported to the healthcare provider are again anaphylactic reactions and should be discussed with the patients. You also need to notify patients, parents, or guardians of the risks and benefits of each individual vaccine and give them the standardized information pamphlets.